The Society for Vascular Surgery, under the leadership of Richard Cambria and Peter Glavitsky, has initiated audiovisual interviews with pioneers of vascular surgery. This is part of an effort by SVS to develop archives to preserve the history of SVS as well as vascular surgery as a specialty. A committee was formed called the History Project Work Group, chaired by Jimmy Yao, with Norman Rich and myself as committee members. Because of the workload, an expansion of the committee was needed. Bill Baker, Mark Eskandari, Walt McCarthy, William Pierce, Melina Kibbe, and Peter Lawrence were added. Since September 2011, we have interviewed some 50 leaders. SVS has also recommended that these interviews be extended to honorary members as well. Today, we're fortunate to interview the legendary surgeon and leader and educator, Dr. Frank Veith. Thank you, Frank, for agreeing to this interview.
Pleasure to be here.
Every story has a beginning. So let's start with your beginning, your early years in New York.
I was just an ordinary child, I guess. No brothers and sisters, of an Irish mother and a father who was of German extraction. And I went to public school and then to a private high school and then to Cornell.
Well, let's back up for a minute now. Tell me about the grandfather who was the German businessman.
Yeah, I had a interesting grandfather who I never met, who was came over as a 14-year-old boy, basically an orphan without parents. His parents may have been alive, but were back in Germany, and he started a business, import-export business with regard to sequins.
Yes.
And he became very wealthy and very successful because of the thrust towards the sequins in the 1920s. He became very wealthy, and then his half-brother managed to steal the business from him, so he became less wealthy, which is why I had to work.
You've spoken about your public school for your grammar school education and high school in Riverdale. What was Frank Veith interested in those days?
I can't really, mostly sports, and not very interested in school. I really don't have, I was interested in my friends and having a good time, I suppose, but not very school-oriented.
You weren't exactly academically oriented at that point.
Not at all.
But you went to Cornell in 1952.
I graduated in 1952.
Okay.
1948 was when I went there.
Okay.
And there was nothing distinguishing about my career in college.
But wait a minute, now you're minimizing that. You graduated with honors and were 5'8".
Yeah, I actually did well in college because I probably was terrified of not doing well, and so I studied a lot and got good grades, yes.
Now, why did you decide to do medicine?
It's hard to pick a reason. My mother had been a nurse, and she'd always pushed me towards medicine. I had an uncle who was a dentist, and he had pushed me towards surgery, at least having some interest in it, or encouraged me to take. My father was a lawyer, and I knew I didn't want to do law because he was always coming home at night and having to work on paperwork, which I didn't particularly want to ever do. I wanted to work with my hands or my head, and it turns out, obviously, in academics I was doing the same thing that he did, coming home at night and dealing with paperwork.
Now, after 3 years, you were able to go to medical school.
Went to medical school. I actually went to Cornell because I had gotten a full scholarship from New York State. I was accepted to Harvard Medical School also, and I think probably made the wrong decision in not going there. But I did go to Cornell, and that worked out pretty well too.
Now, why did you decide on surgery now? You said the dentist uncle encouraged you, but
No, that wasn't the reason. I was always interested in the intellectual part of medicine, and was thinking very seriously of internal medicine.
Hmm.
And because it was intellectually challenging. And then I had this one experience where I took care of a patient as a medical student with a perforated ulcer, made the diagnosis, went to the operating room, saw the procedure completed successfully, saw the patient get well, and that convinced me that I would be more inclined to be engaged in, especially where there was active participation and where you could see the results quickly of what you did. And that got me into surgery. Plus, we had a animal surgery laboratory where I realized I could do the procedures, and that also prompted me to go into surgery.
Now, you finished medical school as #1 in your class.
Yes, it did.
So when you say you weren't doing that well academically, that's a little modest, right? You
Well,
were doing very well.
I guess I did okay, but again, it was mostly fear rather than intellect that prompted me to work hard and get good grades.
So you went to internship now, again in New York.
I went in Columbia Presbyterian. I was torn between going to one of the Harvard hospitals and Columbia, and I actually probably could have gotten into either, but I chose New York, I guess, because I wanted to stay close to my family, which was probably a very stupid thing to do. There was a bad reason for choosing it.
But now, after your internship, now you do go to Boston.
Yeah, I had a very planned deferment
Right.
from the Army, and Columbia wanted me to go in the Army after my internship year, and I didn't want to do that. I wanted to be trained and then go into the Army. So I applied for and got into the Brigham, which had been my first choice if I had
Right.
gone to Boston.
Now, you did go into the military, though, in 1960.
Yeah, after I was pretty closely trained, pretty fully trained. I was board eligible, but I had not finished my chief resident year at the Brigham.
Was this time well spent, or was this wasted
Army?
time? Yes.
The Army was outstanding. I mean, I was the chief of surgery at Fort Carson Military Hospital, which was a fairly big hospital serving Colorado Springs, the
Oh.
Air Force Academy, etc. And so I did more surgery at Fort Carson after I built up the confidence of the hospital commander than I had done probably throughout my whole residency, and actually became consultant in pediatric surgery for the 5th Army area and stuff like that. So it was a very positive experience surgically, and it was also a nice place to be.
When you finished your military obligation, you went back to Peterbilt Brigham
I did,
and finished as a chief resident there.
correct.
Why were you so drawn to Harvard? Why not stay
Well,
in New
there
York
was a
the
guy
whole
named,
time?
the head of surgery at the Peterbilt Brigham was a fellow named Francis Moore,
Right.
who was an awesome individual
Absolutely.
in many ways, the preeminent surgeon in the world at that time.
Yes.
And that was a huge draw because of what he did and what he meant and so forth. And I just felt it was the best place to get trained.
And he had trained David Hume.
Trained David Hume. He was an awesome guy. He was an excellent surgeon. He was a brilliant intellect. Many of his colleagues and contemporaries didn't think he was a good surgeon, which was nonsense. He was a brilliant surgeon. He did most operations he did beautifully, and it was an inspiration. He was good at everything he did.
Now, in 1963 through 64, you did a postdoctorate fellowship at Harvard Medical School. Doing what? What was that all about? Was
Well,
that when
I-
you got the Markell Scholarship?
No, I got it after that.
Okay.
But the every resident that went through the Brigham program had done some research, and I managed to get through without having spent any time in the laboratory. And I'd had 1 or 2 publications, maybe 3 or 4, but I really hadn't done basic surgical research. So I decided after finishing my training that I did probably want to pursue an academic career, and I felt that I should spend a year in the lab. And I spent it with Joe Murray as my instructor or guide, and I did work both in liver transplant and skin transplantation. And he was my mentor, as it were. I'm very fond of Joe Murray in many ways. And that was a good year, too. I mean, I got a lot out of it. We got some publications, and I got introduced to the academic milieu, presenting some of this work at the Surgical Forum and stuff like that.
Now you've completely finished your training, and you decided to go into practice. Why academics?
Because I guess I had done well academically. The people that I aspired to be like, Francis Moore, Joe Murray, Chilton Crane, John Brooks, these were all surgeons who I respected a lot. They all were academically oriented, and they encouraged us to do the same. But I did think of going into private practice, but basically I thought that it would be better for me, a better fit, to remain academically intensely affiliated, so pursue an academic career.
To pursue an academic career, you went back to New York in 1964.
Yeah, I would have liked to have stayed at Boston, but there were no jobs at that point. Being chief resident at the Brigham was a unique experience because the second most powerful guy in the institution was the chief resident. More powerful than any of the other, more responsibility, power, etc., authority than any of the other attendings. And I think Dr. Moore probably structured it that way because you were sort of a semi-god for a year. When that year ended, nothing. And so there was no second in command really at the Brigham. The chief resident was the second in command administratively, and it was a great experience. But it also was a bit of a letdown when it was over.
Bigger letdown yet when you decided to go back to New York.
Well, as I say, I would have liked to have stayed at the Brigham, but it was a small hospital in those days. There was no job, and although there were some ancillary jobs in Boston, I felt that a better academic opportunity was with the Cornell service at Bellevue.
What did you find there, Frank?
It was a hellhole in many ways. It was a good experience in some ways. I mean, I managed to get an NIH grant and continue to do some research, but as far as doing clinical surgery, it was, for me, it was not much of a job.
The surgery you were doing then was general surgery, right?
Well, it was general surgery and whatever vascular I could get my hands on, because vascular surgery was a part of general surgery in those days.
In 1967 now, you moved to Albert Einstein.
I did. I was forced to move because Cornell and New York City got a divorce, and Cornell was either forced or elected to leave Bellevue. So the service that I was affiliated with was no more. And though I could have stayed at Cornell, it really was not a particularly hospitable opportunity. So I went to the Bronx, to Albert Einstein College of Medicine and Montefiore Medical Center, with every intention of leaving soon to get a better job. But it turned out Montefiore was, at that time, was pretty good, and I stayed.
During this same time frame, you became co-director of the transplant unit. What in the world was that about?
Well, I was basically director of the transplant unit. Marv Gleedman, who was the chief of service, who really didn't know a lot about transplantation, was the other co-director, but I really basically built it and ran it. And I'd learned how to do kidney transplants from Murray and some of the other surgeons at the Brigham, and I learned how to take care of them, so I started the transplant service there. And it was a successful kidney transplant service.
And let's stop right there for a moment. You did pioneering work in clinical lung transplant. What was that about?
Well, kidney transplantation was pretty well established. I mean, it had its frustrations and problems with poor immunosuppression and so forth, but the one area of opportunity where really no clinical success or even laboratory success had been accomplished was lung transplantation.
Right.
It was a large organ, it had vascular anastomoses. It was in many ways frustrating and unexplored, so I thought that I would embark on that particular area because it represented an area of opportunity in which no clinical successes had been achieved.
Now, who taught you about how to do this?
I taught myself, obviously. I mean, I read and it wasn't just clinical. I mean, we did a lot of animal work as well. And over the years, I was successful in getting NIH grants, a program project, and so forth, all designed to solve the problems that prevented lung transplantation from becoming a clinical reality. And during the course of that, we did, I think, 8 or 9 clinical lung transplants, single lung transplants.
That were successful?
Well, 1 or 2 of them were quite successful. They weren't perfect. They weren't long-term survivors. One patient survived for 6 months. This was before cyclosporin. And the thing that we did is we proved conclusively, both in animals and in man, that a single lung could provide total pulmonary function for the patient under appropriate circumstances and if rejection could be prevented. And we proved that first in the animals, proved why others hadn't been able to do it, showed why they couldn't do it, showed how to correct that problem, and then took that to the bedside and did patients that really had no function in their other lung. And this one particular patient that we did was really quite successful in documenting that an emphysematous patient with pulmonary hypertension could be basically cured with a single lung transplant.
Wow. In the 70s and 80s, you redirected your attention, this time to vascular surgery. Why was that?
Well, I never really redirected it because I was always interested in vascular, but my research interest was in lung transplantation. And I realized there were lots of problems getting donors in New York City. The other hospitals weren't particularly cooperative, although they would accept organ donation for what they were interested in, typically heart transplantation. They wouldn't share their donor lungs with us, and I realized that I couldn't make a living doing lung transplants, even though I thought we could make them work. And I also realized that I still liked doing clinical surgery, and so I basically had 2 careers going at the same time, one in a research area, the lungs, and the other clinical vascular surgery. And I gradually moved more and more into vascular surgery because of the challenge that presented and because of the fact that it allowed me to take care of lots of patients.
By 1971, you were now a full professor at Einstein, and by 1972, you were chief of vascular surgery at Montefiore.
Right.
So you had rapidly moved up the academic ladder.
Yeah, that went pretty well. But remember, it was not the first-rate hospital that some of the other institutions in New York were, and so it was easier to move up quickly in that somewhat disadvantaged environment.
Currently, Frank, you're now the professor of surgery and the von Liebig chair in vascular surgery at Cleveland Clinic. How were you able to move that? The last time I checked, Cleveland was not in New York.
No.
How did you move?
Well, actually, my current appointments are at NYU in New York, where I have a professorial appointment, and where I do my limited clinical work at present, see patients, operate a little bit here and there. And as I know, we run a big meeting, vascular meeting, which...
We're going to come back to that.
Which basically, when I left Montefiore, I needed a sponsor, both from the CME point of view and from a financial point of view, and so I affiliated with the Cleveland Clinic, and that is the basis for my Cleveland Clinic appointment. I did go there and do some limited clinical work at the beginning, but really I don't do anything there at present.
But you were able to transfer the or maintained the von Liebig chair when you left Montefiore. You took that with you.
It's an interesting story. No,
Yes.
I didn't take it with me. Montefiore actually, although the chair was given to me in perpetuity by contract till I was no longer active, they didn't see it that way, and they managed to take the chair. So I called up the Liebig Foundation and I got a second chair, but the money was kept by Montefiore, which was actually, I was told by attorneys, actionable, but I chose not to take any legal action.
Frank, you've also been involved in numerous important committees, editorial boards, including the Journal. During this time, you mentioned Franny Moore as a mentor.
Mm-hmm.
You had other mentors,
Absolutely.
I'm sure.
Dwight Harkin who's a cardiac surgeon of considerable renown, also at the Brigham. He was very much a mentor. I patterned my clinical work on the way he ran his service. In other words, giving residents a great deal of responsibility, both in and out of the operating room, making them partners in many ways, in a big clinical effort. So I basically followed his pattern of setting up a clinical service, and it worked. It worked very well for me.
Who other?
Well, Chilton Crane and Richard Warren were the vascular surgeons at the Brigham. If they were general surgeons but with an interest in vascular surgery, they were very influential. Chilton Crane, particularly in my case, although Richard Warren, I guess, equally so. John Brooks, again, another individual who's no longer with us, was very influential. He was a first-rate academic and clinical surgeon. And another fellow who was really my chief resident when I was a senior resident, Richard Wilson, also a very fine general surgeon, was a friend and a mentor.
I think it's safe to say that you have received massive awards and recognition, not the least of which was in 2010, you received the SVS Distinguished Lifetime Achievement Award. You've led every significant surgical organization in the country. You have a staggering number of publications, some 744 by last count, and a large number of book chapters, 339. The list goes on and on. How did this all happen to this young man from New York City?
Well, I had a lot of good partners, and we again, following the leadership of some of my Brigham mentors, I structured my service in a way that it was really more of a partnership between equals than it was an autocratic, typical surgical service. And I obviously was very interested in publishing the work that we did. It was a very important part of making our work known, getting support, and so forth. So I encouraged my partners to write lots of articles, and I shared the authorship in many cases with them, and sometimes I'd write the articles and they'd still be the first author if they were the leader in that particular work. And we did a lot of stuff in vascular surgery that nobody else had deemed possible over many years, a many-year period, and so a lot of that stuff gave rise to good articles, and if we had the material, we wrote them, and of course, when we started doing endovascular, every case was unique, and every group of cases were suitable for writing articles.
With all this success, when you look back, do you have tips? Do you have specifics about time management, for example?
No, basically it's persistence and hard work. I mean, the writing usually had to be done at night or on weekends, and other activities sometimes had to be sacrificed. And so, as I say, persistence and hard work usually I mean, the papers don't always get accepted, even if they're good or about a good topic, and they require rewriting, editing, and often submission to another, even better journal than the one that sometimes rejected it. Some of our best work was rejected because people didn't believe it. And by persisting and, as I say, sometimes sending it to a better journal, we usually got it published sooner or later.
Despite all this wild success, did you have any failures, Frank?
Lots of failures. I mean, clinical failures. I mean, cases that we thought we could have a chance at doing that didn't turn out to be successful. But my biggest failure was the inability to make vascular surgery succeed in attaining specialty status, real specialty status, as an independent specialty rather than a subspecialty.
We'll talk some more about that shortly. What lessons did you learn from failure?
What lessons? Well, to try something else. I mean, if something fails, first of all, you have to be very persistent. And just to go back to the board situation, I was enormously persistent and committed to it for many years. But when it failed and it was obvious to me that it wasn't going to succeed, probably for a lot of bad reasons, I basically said to myself, you have to walk away and do something else. And that's basically what I did. And so I think that failure is part of life. It's certainly part of vascular surgery.
Oh, yes.
And you can have a failure that by persistence you can turn into a success. But in the case with the board situation, I thought was hopeless, and so we turned our attention to other things.
Change gears for a moment and talk about your immediate family, Frank. Tell us about your children. And
well, I have 4 children and 12 grandchildren. And my relationship with my kids probably suffered somewhat from the fact that I was always working, and probably suffered from the fact I didn't pay as much attention to them as I might. But I have a better relationship, at least with most of my grandchildren, and I probably have more time that I can at least think about them and try to be supportive. So I think that everything has a price, and some of what you call success, I call it hard work, obviously has a price.
Any lawyers in the family?
2 sons are lawyers, and my 2 daughters are basically, they work, but they're not career women.
No MDs?
No MDs. Perhaps some of the grandchildren will go in that direction. I don't know yet.
Frank, I'd like to go back and spend some more time in particular areas, focus areas of interest. The first being to talk about your pioneering work in limb salvage for severely ischemic legs. You entered this arena when amputation was a frequent outcome. How and why did you engage?
Okay, that's a very interesting question.
Yeah.
Again, you don't realize it at the time, but when I went to Montefiore, which was a poor hospital with lots of indigent, disadvantaged patients, I of course wanted to do aneurysms and carotids like every other vascular surgeon was doing and writing about, and we didn't have many of those cases, but we did have a lot of people that had gangrenous limbs, superabundance. And because I recognized that the standard treatment for these patients was just to take off their legs, either above or below the knee, I said, maybe we should try to save some of these legs. And we had extremely good angiography. Largely, well, I was involved in that too. The surgeons were doing their own angiograms and they weren't so good. So I made sure, it was probably a mistake at the time, but I made sure that I got the interventional radiologist that was working with us to do all the angiograms. And he became extremely proficient because he was doing them all. So we had super angiography, where we could see the little vessels in the lower leg and foot no other institution was getting that. And when I'd see a vessel, I started to try to do some bypasses to these vessels. This was before anybody was attempting limb salvage much below the knee. There were a few case reports, but nobody. And some of these procedures worked. So when they worked, we did more and more of them. And again, with the good angiography, we started to get patients from other hospitals that were deemed inoperable because they didn't visualize the foot and the ankle. And we'd find a nice big fat vessel in the foot or at the ankle, and we'd do a bypass to it, first with vein, and when we ran out of vein, we used prosthetics. And remarkably, these procedures worked better than anybody could imagine, even when there was extensive gangrene. And we'd show pictures of these cases, and people wouldn't believe us. They say, you can't do that, you're lying, da-da-da-da-da-da. So we collected series of these cases and documented them and had people come and look at the, see us do the case and see the patients afterwards and so forth. And it became apparent that this stuff could be done, and it did work, even when I didn't think it could work. Remarkably, bypasses to very little vessels in the foot and at the ankle could work and did work. And they persisted, and they allowed the foot to be salvaged even if you had to take off all the toes or the heel or whatever. So we collected more and more of these cases and kept writing about them and showing them. And ultimately, after 10 years of being regarded as a maverick, crazy person, a radical, as John Manick would say, people started to believe it and duplicate it. Not everybody could duplicate it, but commitment was a very important part. And I had partners and fellows and residents, and with the resources that they provided, wasn't just me, we all could do this. So we must have taken care of 4,000 or more patients over the years with true ischemic gangrene or ulceration, not trivial gangrene, big league stuff. And and then we started using angioplasty very early, because I was, again, supporting our radiologist. I sent him out we had Dotter come to the New York Surgical when I was president. I invited Dotter to come. Nobody believed him. They all thought he was crazy, footprints in the snow. But I said, maybe this guy is telling the truth. And I sent our radiologist out to observe him and start doing angioplasty. And he went out there, spent a week, and came back, and we started doing angioplasty before there were balloons. And they worked. And in these old, sick patients with dead legs or dead feet, much easier to do an angioplasty of the iliac if they had multi-level disease than to do an aortobifemoral bypass. So we started doing them routinely. And I think we published very early on in the late 70s or early 80s that angioplasty did work.
But how can this work, Frank?
How? It just did.
How can you put these metal stents, metal cages inside of blood vessels?
We didn't have metal cages. These were Van Andel catheters. They were just tapered catheters that would stick over a guide wire through the plaque, dilate it, improve the flow, and then about 3 years after we started doing that, the balloon catheters were introduced.
But how can you mash plaques, mash them and crush them, and expect this to work? I know it does work, but
well,
how do you rationalize?
We now know how it works. But first of all, what Dotter said wasn't true. It wasn't that wasn't the footprint in the snow where the plaque was compressed against the wall. What was happening was the normal adventitia of the artery was being dilated.
Right.
So the lumen was actually increased. And then of course, there were dissections. And we didn't think it was going to work either, because in the operating room with dilators, it doesn't work. But in the setting of the angiography with guide wires and sheaths and stuff like that, it does work. But sometimes it didn't work because there was a dissection and it would thrombose. But with stents, when they came along, immediately we embraced those, and they did work. We would plaster the dissection up against the wall of the artery. So again, I didn't really think it was going to work, just like with the lung transplant, because the literature said it couldn't work. A denervated lung had high resistance, so you couldn't transplant a lung in a patient with pulmonary hypertension. Well, we showed that the resistance was at the anastomosis, the arterial anastomosis, as the artery dilated, became a point of relative constriction. So if we eliminated that constriction, the resistance was normal in the rest of the lung. And we documented that. That was an article in Science. But similarly, with the angioplasty, I didn't think it was going to work either. But it did. And as it worked, we did more and more. And then we started to do angioplasties of the SFA when we had appropriate lesions. As the technology improved, we realized we could do more. But I would not do the angioplasties. I would refer them to our radiologist to do. Mistake. But that's how we did it.
Bad mistake. Mm-hmm. Now, let's talk about the first United States stent graft done with Juan Perotti. Can you expand on that and tell us about that case?
Well, I'll tell you a little bit of the background, because we just had the 20-year anniversary at our meeting where Juan and Claudio Schoenholz and Mike Marin and I were celebrated for doing it. But what happened, because I'd supported Barry Katzen early in his career. When he was through his training, I invited him just out of his training to talk at the New York Cardiovascular, I guess when I was the president, because I thought maybe there was some interest in, or some merit in lytic drugs, which he was proposing. So I invited him to speak at on that at our New York Cardiovascular, and he never forgot that. So he would invite me to his meeting, his radiology meeting in Miami, and I would go and I would listen, and I would hear the interventional point of view, which no vascular surgeon would accept. This was in the mid-'80s, I guess. Mm-hmm. And I realized that maybe there was more to this than met the eye. And we were doing angioplasties too when no other surgeon embraced it. They were all against it. And they were working. And I think it was in 1987, I saw Julio Palmez talk on stents, and he talked about stent grafts for treatment of aneurysms, and he showed some pictures. And I was very interested in that. And then subsequently, I didn't do any research work on it or start any laboratory or animal investigation, but I was interested in it because of my positive experience with angioplasty. And so then I saw Perotti's article, and we talked about doing it at that time, that maybe there was something to it. And again, most surgeons were very negative about it. And then we had a patient in 1992, the summer of 1992. The patient was referred to me with a big tender aneurysm, very bad risk, and Mike Marin called me up on a weekend and said, we have this patient, what are we going to do? Maybe we should go down and see Perotti and see how he does it and learn how to do it and come back and do this patient. And I thought about it for like 2 minutes. And I said, that's a great idea. I have the money. Somebody had just given us a grant. And I said, let's go down there. And so Perotti knew me, so I called him up and I invited him to our meeting. And I said, by the way, we have this patient. Can we come down and show us how to do this? We'll take it back and do it on the sick patient in the Bronx. We'll bring our x-rays, etc. And he says, well, I'm not doing any more patients right now. So I said, well, maybe you'd like to come up and do the procedure here. And he said, maybe I'll come to your meeting. He wasn't very positive about it, but we pursued it. And we sent him the films. They got lost. We sent another set. And then ultimately, he and Marin met in Milwaukee at a cardiology meeting, and they hit it off. And by this time, I'd developed a relationship with Perotti on the telephone. He was coming to our meeting, so we persuaded him with there was a lot of adversity. There was obstacles all the way. The biggest one being J&J wasn't going to let us use a Palmez stent because they were worried about that impacting on their cardiac stent, coronary stent, the Palmez Schatz. And Perotti had signed an agreement that he was locked in with J&J. So anyhow, we kept overcoming the obstacles. We brought his radiologist, his instrument guy, agreed to do all that, fly them first class, put them up in a hotel in New York, et cetera, et cetera. And after the meeting, we were going to do this case of ours. And so we talked about this last week when we had this celebration for the 20th anniversary. So anyhow, Marin and I took the president of J&J Interventional, now Cordis, out to dinner with one of his colleagues at the Newark Marriott, and they kept saying no, 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 no. And Marin and I, they were sitting at a table in the corner, and they were in the corner. We wouldn't let them out of the corner for like 4 hours, and the restaurant was closing, and the chairs were on the tables and everything. And finally, they got so tired, they said, "Do whatever you want. We don't care." And so we overcame that obstacle. We got Perotti to come. He came to the Bronx and saw what, awful instrumentation and stuff we had there. We had a borrowed portable fluoroscope that cardiology had thrown out, and we're very primitive. So Perotti said to Schoenhaus, "We got to leave. This place is much worse than it is in Argentina. It's the fourth world. We're going back to Argentina." But we persuaded them to stay, and we did the case, and it came out pretty well.
Did he do the case, Frank?
Well, we helped. I mean, we did parts of it, but I mean, he basically, and Schoenhaus, did all the catheter wire work. But the interesting part of that case is when I saw it, I said to myself, I mean, it was like a lightning bolt. I said, if vascular surgeons aren't doing this, we're out of the game. And so it was really a seminal event for me.
Right. Lights went off.
And it turned out that I was increasingly important in some societies, including the SVS, in the next 3 or 4 years. So after that case, we had him come up to do 3 other cases, one of which ended badly, one ended sort of neutrally, and one was positive. But it wasn't all the first case was. I mean, we saw that there were problems, or there could be problems, but we pursued it. We started making the grafts ourselves, Marin and I, and we were the only 2 that could make them. And we made them from Palmez stents, some of which were commercially available at the time. Or we bought the stents from Argentina. So we did a bunch more cases, and they worked. We used it for occlusive disease, for trauma. We used it for everything, and for aneurysms, and they worked. And so we went to present this to our colleagues. There was a vascular surgery biology club, and I brought Perotti and Marin, and I gave the presentation. I guess Jerry Goldstone was running the thing, and he said, "We already have a presentation. Jack Cronenwet is giving an hour's talk on co-culturing smooth muscle cells and endothelial cells. So you can wait until next year." And I said, "Jerry, this is important stuff. Everybody ought to know about it because it's going to change the way you do stuff." And he says, "Oh, the hell with it. We'll give you 10 minutes. I'm just the secretary. You do what you want," because I kept persisting. So I got 10 minutes to present this at the Vascular Surgery Biology Club with all the then leaders at the time. And I thought I was going to be greeted like a hero. We had 25 cases. I had Perotti sitting in the audience, Marin sitting in the audience. We couldn't, 3 of us, be lying. So we presented these 25 or 30 cases, and nobody in the audience believed us. Chris Aarons didn't believe us. Wes Moore didn't believe us. Jimmy Yao didn't believe us. Jim Stanley, my good friend, didn't believe us. I don't think Bob Rutherford, nobody believed us. And certainly John Porter was very derogatory. And he said, "You're lying." And he says, "If you're not lying, you shouldn't be doing this stuff." So I got very depressed. And we went out, we had a beer, the 3 of us, and Perotti says, "That's exactly how I was treated in Argentina." And so we we sent a paper into the SVS. It didn't even make the cut. They rejected it, in the dregs. So we kept at it, and obviously it kept working. And then I gave a presidential address at the Eastern Vascular in 1994, and I made that the topic of the address. And I said, if you guys don't learn this stuff, you're out of business. And then 2 years later, I gave my presidential address at the SVS, on Charles Darwin and vascular surgery,
Right.
and I had 3 points. One was, if you don't become endovascular competent, you're going to become extinct. Secondly, we had to become an independent specialty because this would define us and separate us from cardiac and general surgery. And thirdly, we had to form centers with the interventional radiologists so that we could learn from them and support them. And tongue-in-cheek, I was concerned that it would give us protection as vascular surgeons against cardiologists who were then becoming more active in this area. I was wrong about the centers. They didn't work too well. I was right about the board and independence, but we lost that fight. But now, as you know, endo it's 9/10 of every SVS meeting, and it fills the journals. I mean, nobody's interested in instruments and open operations anymore.
Tell us about doing the first ruptured aneurysm using the endograft.
It was natural. I mean, we made our own graft, and it was sterile. Marin would run it down to the gas sterilizer. We'd make it, you'd take it down there, and you'd come back with 1 or 2 of these grafts, which took a couple hours more to make. And so we had a stock of them. And we kept saying, if we have a ruptured aneurysm, we should do this, because we did terribly with ruptured aneurysms. We had about a 70% mortality because of the nature of our population. Even though we thought we did the operation very well, I used to write about it and all, and how to make the diagnosis, or it didn't matter, they still died. So we had a patient that was inoperable with ostomies and scars and hernias and terrible heart, and a ruptured aorta. So we did this fellow, and he got better. He lived for, I think the first guy lived for 3 years or something.
Now,
I can't remember, but he got better immediately.
How did you know that you had an adequate neck?
I think we did an angiogram. We were doing, I guess we had CAT scan and angio on the first patient. And we wouldn't get CAT scans on everybody because our CAT scan accessibility was poor.
Logistics are
The logistics were terrible. So we would just, once we had a ruptured aneurysm, we'd do everything angiographically with measuring catheters. And if we had any neck, we did it. If we didn't, we opened them.
With more vascular cases being done using endovascular techniques, open cases are certainly on the decline, as you've mentioned. Is this a problem for training in your mind?
Terrible problem.
Right.
Well, because you have to do, for example, distal bypasses. I think you have to do 50 to 100 to be competent. Our residents don't do that many. They're lucky if they do 10. And it's not an area of excitement and interest anymore. There's still some people that are very capable, that are well trained and can do them, but many surgeons can't do them well. Many surgeons could never do them well. You know, the vascular surgeons, many guys, they didn't have the patience and the commitment. Some of these cases used to take me 8 or 9 hours, particularly a redo. And then after you're all done and you get an angiogram and it's not perfect, you got another 3 hours to fix it, if you can. But that was part of it. And so the procedures are long and tedious, whereas endo, if it works, is quicker, but still can be tedious. The very distal endo cases are hard now, too.
Well, with the dominance of endovascular, certainly fewer general surgeons are trying to do vascular surgery now, which perhaps is a good thing.
It's a good thing for the patients.
Right.
And they still do fistulas and veins and amputations, which I think is a bad thing for all concerned. But I think we should have enough vascular surgeons to do all vascular cases. And I think an amputation, if it's done by a general surgeon, he's not going to know whether or not that patient can have a successful salvage of the limb. And he'll do the amputation. But now our competition comes from cardiology, interventional cardiology, a little bit from interventional radiology, although I think that's not threatening in any way, and from cardiac surgery. I see cardiac surgeons who don't have enough to do in the heart, who are becoming more and more interested in doing renal angioplasty, carotid angioplasty, leg angioplasty, and certainly abdominal aneurysm and thoracic aneurysms. And they can learn.
Right. Speaking of the training in vascular surgery, discuss for a moment the 05 training program for vascular surgery. What are your thoughts there?
I think it's a positive. I mean, I think that's the only way to go. As I still go to our general surgery conferences at NYU, and I find them interesting, but I'm a civilian there. I don't know anything about what I know very little about general surgery today. I certainly don't understand the procedures that they do. It's all done laparoscopically. Now, a lot of the cases are done for weight loss surgery, which is totally beyond me. I don't know any of the facts or anything like that. It's a different specialty, and we're a different specialty.
Yes.
And so I think a 0 and 5 is a natural. Whatever general surgery techniques the vascular surgeon has to learn can be learned by attaching him to a general surgery service. So he learns how to do laparotomies, thoracotomies, and so forth. But I think it's a waste of our valuable training years to learn how to do adrenalectomies or breast surgery or thyroid surgery for that matter. We should focus on what we're doing and expect it to do well, and there's plenty of it to fill 5 years.
Oh, yes.
We have to learn imaging. We have to learn non-invasive and invasive diagnosis. We certainly have to learn open and endo surgery, and we have to learn how to take care of the patients, and we should learn medical treatment. And all that will fill up 5 years very easily. So I think it's a huge advance. I think the 5 and 2 is sort of a, I don't know, there's a word, it's a throwback to historical throwback, and probably there are very few vascular surgeons that are going to be asked to do a lot of general surgery because it's a different specialty now.
Right. Frank, you've never been one to shy away from difficult issues, particularly the issue of vascular surgery as a distinct specialty. You, Jim Stanley, and many others, including me, fought for independence for years. Many felt that vascular surgery was just as clearly a distinct entity as neurosurgery or cardiothoracic or orthopedics. And yet, in the final analysis, independence was denied by the American Board of Medical Specialists. Why? Was this purely political, Frank?
Yes. I don't know, maybe it was economic as well as political, but it clearly was certainly political, and because we fulfilled all the necessary criteria in the bylaws of the ABMS to have an independent board, and the application, which was 2 feet tall, basically documented that. But we were told during the process that we shouldn't bother applying because it would be denied. And then after we were denied and appealed it, we were told that our appeal would be denied. And yet when we actually tried to lobby Congress to support us because we felt this was in the interest of patient well-being. And when some of the individuals in Congress called the American Board of Medical Specialties and asked why we were turned down, the answer was, and I was sitting in the room on a speakerphone listening, the answer was, we don't know, we don't keep records.
Yeah.
I'd say that's political.
I'd have to.
Yeah.
But do you believe that this forced the American Board and others to make significant changes that were in our favor?
We got some booby prizes.
Okay.
We got some compensatory things given to us, one of them being the 0 and 5 program, which was beneficial. And we had something called the primary certificate, which was a token that maybe made us a little more independent, but still didn't make us a fully independent specialty. And my belief today is that though our training has been improved, remarkably by our effort, and will continue to improve because it's the right thing to do, with more and more 0 and 5 programs being coming into being. I think one of the reasons that I'm disappointed, or that our specialty should be disappointed, is that administratively we're still regarded as a subordinate subspecialty. And in many institutions, medical schools, and hospitals, not all, vascular surgery has to go through an administrative structure which is comprised of general surgery or cardiac surgery. In other words, they're subordinate to that administrative structure. So we don't have necessarily, oftentimes, in some institutions, not all, we don't have a seat at the table.
No, we don't.
And so that we're not equal, we're not playing on a level playing field. And as a result, vascular surgery can't develop and evolve and prosper to the extent that I think it deserves to prosper.
Let's talk about the Veith Symposium, which has been going on for how many years now, Frank? 30?
We just finished the 39th annual meeting.
Wow.
And it wasn't always, the name evolved, and it's not my name, it's an acronym. Vascular, endovascular, interventional therapy,
But
horizons.
this has always been your meeting, Frank, even though when it was called
it was originally called Critical Issues in Vascular Surgery.
I know, but this was, the driving force has always been you behind it.
Well, Henry Hamavici started the meeting before I did. I think he had 3 or 4 meetings before I took it over. And it was a small meeting. It had maybe 100 or 200 people, 10 or 15 faculty. But it's grown progressively over the years, in part due to good fortune, and in part, hopefully, due to some good management.
How many people attended this year?
We had close to 4,400. I
Wow.
use the figure that I think. Now, not everybody was a paying doctor, but the total attendance was 4,400.
Amazing. This is certainly the largest and most respected educational meeting for vascular surgery worldwide. The innovations, which have been many in this symposium, have included the short 5-minute presentation. How did you make this happen, Frank, without a revolt of all the presenters?
It wasn't easy, but it was in some ways good luck. I wanted to have more faculty because people had good things to say, and I couldn't get them into a compressed enough period without making the talks very short, so they got shorter and shorter. They're not really they're 6 minutes, not 5. They're given 5 minutes, but there's a minute that they can run over a little bit, and for transition. So they can keep talking a little longer than 5 minutes, and most of us do. Most of them do. It's very hard to give a 5-minute talk. It takes a lot of work, but it works. And as long as you enforce it for everybody, they accept it. And that way I can get 2 or 3 talks in for one person if they have 2 or 3 good ones. And the other thing that prompted me to do it, if you watch a television interview with, say, Henry Kissinger, he doesn't get more than 2 or 3 minutes of talk time, and yet he gets his points across. And so people have gotten good at getting it across in the allotted time, and the real secret, which again I stumbled into, is having a clock on the screen so that the speaker sees it as well as everybody else. They don't want to talk over, but if you just put a clock somewhere off to the side, nobody looks at it. They're looking at their slides. So by putting the time on the slide, he has to look at it. He can pace himself, and he knows that if he goes over the 5.5 minutes, the slides will go off. So he finishes, and it works. It's effortless. It used to be tremendous effort on my part. I used to have to go up there and tap him on the shoulder and then pull him off and, jokingly put my hand over the microphone. But now it's automatic. It works.
It really does.
And yet there are disadvantages. I mean, some people would like to hear more, but then you can't get as much in. And in general, a lot of what you give when you give a 10-minute or 15-minute talk is background. It's unnecessary.
The Charing Cross meeting was certainly patterned after your symposium.
I'm not sure that Roger would agree with that. He'd say ours is patterned after his.
No, I interviewed him a few weeks ago, and it's clear that meeting was patterned after yours. Do you think that the Charing Cross is the EU version of the Veith symposium?
Yeah, I do. I think it's a good meeting. They have a lot of attendees. They get some people that we don't get. I basically learn from every meeting I go to. I don't have that many original ideas. They either evolve through accident or some like the 5-minute talk, or I learn from somebody else and they learn from me. So it's a natural evolution. The trick is to come up with something new every year and have it be positive, and that's not easy. I mean, every year it's like I say to my colleagues, it's like winning the Super Bowl. You win one year, you have a good year, people like the meeting and so forth. You've got to repeat it the next year. So it's a real challenge. Not many teams win the Super Bowl 2 years in a row.
What is your measure of success? Is it attendance, or is it ideas, or how can you measure? How do you know when you're doing well?
Well, attendance is one. Satisfaction of industry. Mm-hmm. They need access to the doctors. It's one of the reasons Obamacare is so bad, that it's trying to separate industry from doctors. That's a terrible thing. That does more harm to healthcare than you can imagine. I mean, it's like separating wives from husbands. I mean, it's hard to have children that way. But anyhow, we are partners with industry. Our ideas, they take to fruition. They have the money and the engineering expertise. We'd be dead in the water without it. And similarly, they'd be dead in the water if they couldn't get ideas from us. And there's nothing wrong with marketing their goods to us, because that's what their business is about. Now, dishonest marketing, that's a bad thing. But we try very hard, if somebody is giving a positive view on one device or graft, we try and get somebody to give the opposite view so that the audience can make up their own mind. And so I think success is measured in number of people who come, how the people like it, whether they come back the next year, whether industry feels that they're getting what they need out of the meeting in terms of honest marketing, and how good the talks are.
Right. Well, it's a tremendous meeting. I'd like to now move to a series of opinion questions that are somewhat brief, but just your personal opinion. The merger of SVS and ISCVS, you think that was harmful as far as international exchange?
No, I don't think so. But international exchange is very important, but I don't think the role of the SVS is to be an international society. I think other international societies should be international societies that may have different functions. The SVS, in my opinion, should represent the needs and requirements of North American vascular surgeons. And it should have political overtones or functions. It should have marketing functions. It should have educational functions, even social functions. But it should be the voice of North American vascular surgery, and particularly U.S. vascular surgery. Now, that isn't to say they shouldn't have international members and that there shouldn't be cross circulation and cross stimulation, but basically the SVS should serve the needs of American vascular surgeons.
Do you see a place for SVS sponsoring exchange and traveling fellowships?
Sure. Nothing wrong with that.
Okay. Now, to a real hot potato, U.S. healthcare. As we all know, this has become a real political football that may be fumbled many, many times in the future. Frank, do you think we've lost our way?
Yes, but I hope I'm wrong.
What is your favorite operation?
I like carotid endarterectomy because it was quick, it was fairly simple, but I got the most satisfaction out of doing difficult aneurysms or distal bypasses. But they weren't my favorite because they were too hard.
Very difficult.
Mm-hmm.
What is your advice now to young vascular surgeons?
Get the best training you can, and try not to be wooed by the economic pressures that are going to increase as time goes on. Marry a rich woman so you don't have to worry about making a living.
What should you be influenced by?
Should me or the young guy?
The young guy.
I guess doing the best thing he can do for his patients, getting people well,
Well, the young
that
woman.
nobody else can get well.
Right.
And not doing unnecessary procedures, which unfortunately the financial pressures are really very tempting to do unnecessary procedures.
Frank, thank you for this excellent interview and for
Okay.
your time.